postgraduate education program. And today we are very fortunate to have a guest faculty, Dr. Vivek Dave, vitreoretinal surgeon from LV Prasad Eye Institute, to teach our PG students. In this series, this is for you, Dr. Vivek. I'm just explaining. In this program, we invite the PG students and we invite a guest faculty in some subspecialty of ophthalmology who teaches them basics of clinical examination. And our own faculty from POS, they join as experts and they also give some inputs. The students can ask their doubts to the specialist and the experts can ask any questions to PGs. So it is an interactive session. So it has been very popular among PGs all over India. I'm very fortunate today to welcome Dr. Vivek Dave, today's guest faculty. Dr. Vivek has been always a very intelligent student, a meritorious student. He has done his MBBS from GS Medical College, Mumbai and KEM Hospital. He did his MD in ophthalmology from RP Center, All India Institute of Medical Sciences, New Delhi. He did his senior residency as well from AIMS. Then he did his VR fellowship from LV Prasad Eye Institute, and now he is consultant at LV Prasad. An excellent surgeon, a great clinician, a very good academician, and a very, very popular teacher. He has always been an achiever. He has got many awards to his credit. The list is very big. I'm going to just say a few awards. Best Paper Award at APAO 2019. He also got the travel grant for that, for young ophthalm. Best Paper at Vitreoretinal Society. Best Poster at AIOC. Best Surgical Video at Telangana. He was the best resident during his PG and he has won many quizzes during his residency. He is also runners-up winner for international quiz at WOC. So that's great, Vivek. You have been always an achiever. He has got many presentations and papers to his credit, more than 85 papers in peer-reviewed index journals. And he has been always invited as guest faculty at national and international meets. So we are really fortunate, and the PGs are very fortunate to have Dr. Vivek Dave as expert faculty today, guest faculty, and who would be teaching basics of clinical examination of retina. So I welcome you, Dr. Vivek Dave, and thank you for joining for POS program today. Our expert faculty, Dr. Nikhil Beke, again a great achiever. He has also always been a topper. He's from my college, BJ Medical Government College from Pune. He did his post-graduation in ophthalmology from PGI Chandigarh and did his senior residency also from there. He's a VR surgeon with HV Desai Eye Hospital and Dinanath Mangeshkar Hospital in Pune. Again, a great clinician and a great surgeon, and again, a very popular teacher. So both of them are going to give a lot of inputs today for our PGs. And our moderator today is Dr. Sachin Kabra. He is the honorary treasurer of POS. He is trained for vitreoretina at Shankar Nethralaya. So he is going to moderate the session. So welcome all PGs, Madhumita and Gayatri, who are going to interact with these great people. But I would say you are really fortunate to have them. So without taking much time, may I now request Dr. Vivek Dave to start his talk, please.
Thank you very much, Dr. Sharma. Am I audible right now?
Yes, you are audible.
All right. Thank you so much. Thank you, Dr. Sharma. Thank you, Dr. Kabra, and the Poona Ophthalmic Society set up for giving me this opportunity. I especially cherish this because the audience is largely residents, and I strongly feel among the kind words that Dr. Sharma spoke about me, a lot of those so-called achievements have the genesis in a strong residency program that I had back at RP Center. Today, I still feel, though I am a practicing vitreoretina surgeon, if you give me a case of squint or a case of plasty or a case of cornea, I may not be able to operate, but largely I'll come down to the correct approach even today, though I've stopped seeing those patients about 10 years back. So without further ado, I'll go to the first presentation that I have. I hope my screen is visible. Right. So as the mandate is clinical examination, you would all agree that actually to have a complete detailed clinical evaluation, you require a patient in front of you. So what I will restrict or way I have modified my talk is to bring certain clinical photographs, certain clinical pointers, some points regarding history taking and evaluation of the patient. And with respect to a little feedback that I had got during the testing round that we had a couple of days ago, I have brought in slides based on basic interpretation of fundus fluorescein, basic interpretation of the OCT, and basic interpretation of OCT angiogram. So time permitting, we will go through that one after the other. If that is not permitted by time, we will possibly see it on a different day. So I will start off. So the objective is not really to have a complete cover of the whole retinal illness spectrum, but I'll try to give you unequivocal point information. I will not put across anything which is contentious or, in my opinion, something which is straightforward, applicable to the clinic. We'll dissipate it in a short time span, staying right to the point. These may not be directly available in textbooks as far as some of these slides are concerned, because they are something that have got assimilated from a lot of clinical experience. So let's come to history taking first. So for all residents, day in, day out, you will be taking a detailed history. You will be asked for history taking even in your examination. And there are certain things which you definitely should not miss. So what would be the history for a patient in an ophthalmic setup? It would largely be loss of vision and then associated with other attributes of vision like redness, pain, watering. So the overall direct primary complaints in an ophthalmic setup are largely limited. And among the most important one is loss of vision. So whenever the patient says loss of vision, always ask for what quality of vision is lost, or in what way did the patient appreciate the occurrence of the deficit. When we say vision, as you would all understand, we do not necessarily only mean the Snellen visual acuity. There are various parameters to vision. There is field loss, there is color loss, there is contrast, there is objects appearing crooked. So there are scotomas. So there are multiple elements to this loss of vision. Hence, it is important to ask for those, because each of those can already lead you to a probable cause in your final evaluation, even before you end up clinically examining the patient. So here is a small table that I tend to keep in mind when I'm seeing a patient in the clinic. So if the patient doesn't come to you directly with that phrase, then do ask leading questions to try and find out whether any of these deficits are present. So if there is a curtain-like deficit, the probable cause could be a retinal detachment. If there is a curtain-like deficit that the patient finds along with pain while the patient is blinking or rubbing the eye, that could indicate towards ciliary tenderness, which tends to occur when the IOP has fallen really low and the eye gets entangled in a cycle of pain, inflammation, and choroidal detachment and hypotony. So there, the underlying situation may be a detachment with an associated choroidal detachment. If the complaints are of floaters, they could just be a PVD on the innocuous side, or could also indicate towards a retinal break or a vitreous hemorrhage. Mind you, floaters may also come up in uveitis, especially in an intermediate uveitis, where the primary complaint may not really be too much of a vision loss in a quantum manner, but would be in the form of a lot of floaters that the patient may appreciate. If there is metamorphopsia, either again an intelligent patient would tell you that he sees straight lines crooked or straight lines with parts of them disappearing. So either that, or if not, you could actually give a leading question again, point to things in the examination room and ask the patient if the patient is seeing them straight, or is he seeing them wavy or in a mist pattern? That very, very classically indicates a macular pathology. It may not be enough to tell you whether it's a macular hole or it's a macular hemorrhage or there is a CNVM being harbored there or a CSR, but it helps you come down to the possible location in the eye, which is a macular pathology. If complaints are of recurrent visual deficits, again, the commonest in the clinic will be vitreous hemorrhage. Very close would again be uveitis, and always in an ophthalmic clinic, in the back of your mind, do keep migraine as a possibility, because not all patients that come to your clinic necessarily need to have something going wrong in the eye, and migraine can sometimes fall on your clinical or an evaluatory blind spot, and you might miss it and work up the patient for something else, whereas the problem may actually be neurologic, just like migraine. Another important point when one is taking history is always try to recreate a chain of events and gather adequate information. So ask about the onset of vision loss and try to recreate the chain of events in the manner as to how did the patient notice it. So you may see a patient come to you who says that he has noticed a sudden loss of vision since 5 days. So that much sentence would trigger your mind to think in terms of acute causes of loss of vision. But it's important to ask the patient, how did he notice it and what happened with the vision loss from that point in time. Now, suppose you get a history that I was sitting on my couch and I felt something has fallen in my left eye, and I was rubbing my left eye. And while I was rubbing my left eye, I suddenly noticed that I cannot see from my right eye. So this is an incidental pickup. It is not, it does not really mean that the vision problem started at that time point. The vision problem was noticed at that time point. So it keeps the window of possibility open into an underlying a chronic cause of visual loss. This is not very common in the clinic, where often you have patients with retinal detachment, which may be a little chronic, especially inferior retinal detachments, which gather fluid relatively slowly. So the patient may not notice it because vision through one eye is normal. Hence, it is important to ask how exactly did they notice the loss of vision. Temporal profile is again important. There will be illnesses where you will have waxing and waning. There will be something where you will have a sudden immediate loss of vision and then no change at all. So not going into the details, but if you open your books, you will find that each of those temporal profiles will have their own differentials. So once the patient says loss of vision, it is important to ask appropriate secondary leading questions to know what was the exact chain of events, so that you can come down to your possible short, small basket of differential diagnosis. Another important thing is when you have a history of injury with a foreign body. Again, history of injury with a nail or history of injury with a finger is not adequate. You need to again recreate the scene of crime and try and understand what exactly happened. You will be amazed at the number of times that the patient would actually know that the thing that hit his or her eye actually fell off, or the thing that hit his or her eye, the patient is largely sure that it is still within the eye. So that also helps you to understand what is the sort of management approach that you would require. Would you only require a wound repair, or would you already be contemplating a possible foreign body removal? Obviously, the absolute final decision would be made later on imaging, but this is certain sort of ground rules that help you come down to your differentials even at the level of history taking. A second aspect that I would like to discuss is something called as attention to detail. Now, whenever in the clinic, especially in ophthalmology, when we look at our patients, with time, the possible diagnosis occurs to us immediately. So you look at someone and you develop with time something that you call as pattern recognition. So you see a constellation of findings and immediately your mind tells you that this is what is the diagnosis. And many a times you may close down the thoughts towards other differential diagnosis. So here we will go to something called as attention to detail, where we will look at each and every basic clinical finding that you see in a retina and try and then come down to what is the possible diagnosis, and also see that if we go wrong, how it would also have implications. So look at these two fundus photographs. Uh, I think I can have the liberty of asking some resident, what exactly do you observe in these fundus photos? Dr.
Yes,
Sharma,
yes.
would we have that time?
Yeah.
Yeah.
Yes, yes.
If
So they
somebody
can
can,
describe. Yeah.
right. If somebody
Gayatri or
can
Madhumita.
quickly volunteer. These
Sir,
are two different patients. Yeah.
the first image shows a
First one is vasculitis. Vasculitis, sir.
Right.
first one
See,
shows a
so,
disc edema and an inferior retinal detachment.
okay. Right. So again, I will not pause for the want of time. See, both of you gave a shot at answering, right? So I think I heard the first person quickly jump to the diagnosis and say this is vasculitis. All right. I think the second person said that there is an inferior retinal detachment. I am sorry, I did not catch anything more, but there was an attempt to put across a finding. So one person attempted to put across a finding. The other person's mind immediately told that person that it is vasculitis, right? So this is how we can make errors. Now, I want to tell you that you need to, I will account for the right figure also. uh, One has to start with media clarity, that the media is largely clear in both the eyes. Then you come down to whichever part that you want to start with, but start with one part of the retinal anatomy at the time. So the immediate diagnosis of vasculitis, I would not agree to jumping to it like that. Dissect each and every finding so that you are sure that this is what you are dealing with. So for the person who said vasculitis, you would want to first screen the fundus photograph or your patient. Ask yourself, I see XYZ findings in vasculitis. Am I seeing those? Am I checking all the boxes for a diagnosis of vasculitis? If yes, then you will come down to vasculitis. Now, in this given patient, and also the other fundus photograph, though the other fundus photograph, the subretinal fluid is relatively shallow, the arrows currently are pointing to subretinal fluid pockets. The second thing that the arrow is pointing to is a relative pallor of the optic disc in the left photograph, whereas a largely pinkish looking optic disc in the right photograph. The third thing that is being pointed out, if you see the arrows that just came in, are pointing to the caliber of the vasculature. If you look at the caliber of the vasculature on the right side, this caliber is largely normal for the arterioles. If you look at it for the picture on the left side, these are highly attenuated arterioles. So highly attenuated arterioles, a subretinal fluid pocket, flame hemorrhages close to the disc, some cotton wool spots here and there. So can someone put these constellation of findings together and then say what is the probable diagnosis for the left fundus photo? What comes to your
Hypertensive
mind when you
retinopathy.
say arteriolar attenuation?
Hypertensive retinopathy.
Yes. Would you want to qualify your answer further? Do you see a subretinal fluid pocket in almost every hypertensive retinopathy that you see? Hypertensive
No, sir.
retinopathy is not very uncommon, but if you're seeing a subretinal fluid pocket, you are seeing disc edges which are not clear. You're seeing hemorrhages around the
Choroidopathy.
disc.
Choroidopathy.
Yeah, choroidopathy is difficult to comment in a retina which is detached. So this is a malignant hypertensive retinopathy. So the photo on the left is a malignant hypertensive retinopathy. The photograph on the right, difficult at a residency level, but the photograph on the right ended up being a Vogt-Koyanagi-Harada syndrome, which is subretinal fluid in an inflamed eye, but the vascular caliber is largely normal. So how both eyes are presenting with an exudative retinal detachment or subretinal fluid. One is showing severe attenuation of vessels with hemorrhage. For the other, there is no attenuation of vessels and hemorrhage. This becomes a very important distinction, because for the right of the screen photograph of yours, steroids are an absolute indication, whereas in the left photograph, steroids would exacerbate the condition, right? Now, nowhere in the picture, if you see, vasculitis fits in. Why does vasculitis not fit in? Is because when you are commenting on vasculitis, you need to have areas where vessels are sheathed or areas where vessels are showing what we call as cuffing. So that is something that we do not see. Attenuation of the vessels in vasculitis will occur once the vasculitis has gone into a healing phase, not really in a phase where you are seeing the photograph right now. Exudative fluid pocket in a case of vasculitis again is not very common. So when you see individual findings, you will realize that unless those findings fit together, you would be jumping to a wrong diagnosis by immediately committing to a possible final diagnosis. A second thing that I would like to show is common clinical findings: cotton wool spots, exudates, hemorrhages, leaking vessels. So all of these are common clinical findings that you see in the retina in almost every pathologic retina that you see in your OPD. So let us again look at multiple fundus photographs and try and understand the interplay. Quickly again, can I have a resident? I will have arrows. Can I have a resident tell me what are these arrows pointing to? Just tell me what is the clinical finding that the arrow is pointing to.
There is
There are
lattice
multiple ones. So,
degeneration.
sorry, lattice degeneration.
Then there is hyperemic disc. And there are multiple
Are
cotton wool spots.
correct. So can you tell me what are the arrows pointing to? See, again, my question is very specific. So this is again important in your practical examination. Do attempt to answer the way the question is asked. The previous question that I had asked was, can you describe the fundus photograph? Here I'm asking you, can you let me know what are the arrows pointing to? So what are these arrows pointing to? All of them are pointing to the same clinical finding. Are 7 white arrows visible to everyone?
Yes.
Yes, sir.
Yeah. Would anyone else want to try? You had already spoken it. You did speak it. You spoke the word.
They're pointing to
Cotton
retinal
wool
edema.
spots.
Yes, they are cotton wool spots. So these are cotton wool spots. That's correct. Or soft exudates. Now, what are these arrows pointing to? These two arrows that have come in. Can you see those clinical findings are relatively different from the previous ones?
They're hard exudates.
They are hard exudates. Correct. Now, this is the arrow which has come to the optic disc. Now, again, these last two arrows, can you try and make out what are they? What are they pointing to? So hint is this is very much parallel to the first photograph that we discussed. Okay, can you try and understand at least in the lower arrow where it will be relatively clear that this again is a very, very attenuated blood vessel.
Attenuated vessel.
Vessel.
Correct, correct. So attenuation of blood vessels, hard exudates, lot of cotton wool spots, especially in the peripapillary area. All right. So when these constellation of findings come together, you need to again send the patient for a possible measurement of blood pressure. So this is a hypertensive retinopathy. So among the multiple things that we just spoke of, cotton wool spots are predominating here. Now let's change the patient and see how similar findings, but the quantum changes and how it points to something else, right? Now here, if you see, look at this photograph. Largely it is white and yellow. Look at this photograph. It starts becoming reddish. All right. Are you all with me? It starts becoming reddish,
Yes.
right? So
Yes,
what
sir.
are you seeing here? A
Flame
lot
shape
of,
hemorrhages.
Great.
Flames.
Flame-shaped hemorrhages. And what are these arrows pointing towards? What sort of hemorrhages?
Dot and blot hemorrhages.
Yes, they are large. So they are blot hemorrhages. So flame hemorrhages, blot hemorrhages. So I hope you have already caught the point that the most prominent finding here is already different than what I showed you in the previous photograph. All right. Now, what is this that has come in? What is this arrow? What does it look like?
A new vascularization.
It's whitish in color, right?
Again, a cotton wool spot.
Absolutely. It's again a cotton wool spot.
Yes, yes,
Right?
cotton wool.
Correct. But look at the quantum of cotton wool spots. You can look at similar findings in this fundus. Look at the quantum of cotton wool spots in this photograph as compared to what I showed you previously. Here you actually have to search for them, whereas there they were much, much more prominent. All right. Third one, what is this?
Drusen.
Yes.
No, drusen would not look so clearly yellowish with well demarcated borders.
Hard exudate.
It's a hard exudate. So you are seeing multiple such small hard exudates and one big patch of hard exudate. So it's a hard exudate, right? Disc again, largely fine. The image is little blurred, but disc is fine. Vessels. Can you look at the vessels? Do you think the vessel caliber is better here as compared to what it was in the previous one?
Yes.
Yeah.
Right?
Yes, sir.
You can make out the vessel caliber much better here, right? So the vessel caliber attenuation is not prominent here. Can someone say what is this last arrow that has come in? What is it pointing to? This is red dot. So what is it likely to be?
Microaneurysm.
Microaneurysm. So now try to put this constellation together. You are seeing microaneurysms, you are seeing hard exudates, dot blot hemorrhages, flame hemorrhages, soft exudates, non-attenuated blood vessels. So when you are finding this constellation in which your cotton wool spots are not really predominating, what would be the first differential that would come to your mind?
Diabetes.
Correct. It's a diabetic retinopathy. So this is how these are similar findings, but a little bit of tweaking of these findings here and there will change the final diagnosis. So instead of hypertensive, this becomes a diabetic retinopathy. Having said that, always remember, you can also have a mixed retinopathy. You can have features of both. But here I'm just trying to put across the point here is you need to come down to individual observations and then put those observations together in a jigsaw puzzle so that your likelihood of going wrong is very limited. This is a fundus fluorescein of the same patient. Moment you do fundus fluorescein, you will see that so many microorganisms are lighting up and they are becoming prominent. So if I show you this fundus, fluorescein angiogram, you are less likely to go wrong. You're more likely to come down to the fact that this is a diabetic retinopathy. Third photograph, right? Again, can I have a volunteer to try and give me the findings? What is this? Give me the findings, just what the arrow is pointing to. All right. So this cotton wool spot. All right. So cotton wool spot. What are these?
Hemorrhage.
Hemorrhages. So you should always qualify what sort of flame hemorrhages. Correct. What is this? The third arrow that has come in. Fourth arrow rather.
Macular edema. Macular edema.
Correct. Correct. Macular edema. I will just go one step ahead. If you can see, this is looking little round. This is cystic. This is a cystoid macular edema that has formed there. Right. It's a CME, but it's a macular edema. Perfect. What is happening to the vessels here?
Tortuosity.
Great. Excellent. Tortuosity. Right. So you have cotton wool spots again. Again, you have hemorrhages. Again, you have a cystoid macular edema. Right. But the different thing here with the vasculature is you are seeing it, tortuous dilated blood vessels. So what does this put your diagnosis to?
Occlusions.
Occlusion. So always try to give a complete one. Occlusion. So what is occluded? What is in what occlusion is this likely to fit?
Central retinal vein occlusion.
Correct. A central retinal vein occlusion. Right. Again, same clinical findings. Quantum is different. Your final possible diagnosis is little different. Now, these are two angiograms. This is an important point that I want you to take home when you're looking at an FFA later on in your residency, or when you are even doing your fellowships. The angiogram on the right side of your screen is of the same patient of a diabetic retinopathy whom I just showed you. The angiogram on the left side is that of the central retinal vein occlusion patient that I showed you. All right. So you can clearly see you are seeing microaneurysms in the diabetic retinopathy, no microaneurysms in the central retinal vein occlusion. Now, sometimes it can also happen that a person with an underlying diabetic retinopathy can develop a central retinal vein occlusion. It can happen. Nobody stops somebody from having two pathologies. An important thing to know, philosophically speaking, is that diabetic retinopathy is a microangiopathy. Because it's a microangiopathy, the entire background interstitium, everything in the background of these big vessels, these are the large vessels, everything in the background will have some amount of fuzz, because the entire background consists of small capillaries. Whereas in a vein occlusion, the pathology is not a microangiopathic primarily. The microangiopathy in a vein occlusion occurs secondary to the large vessel disease. So you will always see maximum fuzz around the large vessels, and the fuzz will reduce substantially in between the vessels. Can you make out that this area is opalescent white, whereas this area is dark? Can people make out? That is happening because the leakage component is maximally around the large vessels. Whereas in a diabetic retinopathy, the leakage component is largely around microaneurysms and in the background interstitium, because it's a small vessel disease. All right. So large vessels will leak on FFA in vascular occlusions, but the large vessels do not leak in a diabetic retinopathy. This is an important distinction on an FFA, which will help you clinch in case you have clinical findings of both these conditions mixed up together. One small deviation, again, you need to keep in mind. If you look at this, again, this shows you a cotton wool spot. It shows you tortuosity of the blood vessels. It shows you hemorrhages all around the fundus. But if you see, there is a definite pallor of the entire fundus. The fundus is not as much red, full of hemorrhages as you expect in a central retinal vein occlusion. So whenever this happens, always keep in mind that there could be a possible associated arterial component. Because there is an arterial component of occlusion also accompanying the venous occlusion, that is the reason why you do see certain findings of a vein occlusion, but you do not see your classical completely red looking retina. So not a plain CRVO, think of a possible combined occlusion. Same patient's angiogram, and here you can see that even in the phases of 30 seconds, you are having a lot of delayed circulation. From the arterial end to the venous end, there are multiple areas where the blood has still not perfused. So the entire slowing of circulation is very much pathognomic of a presence of an arterial component. I would also request Dr. Beke maybe to interrupt me as and when appropriate and give his pointers to the residents.
Sure, sir.
Yeah. So whenever you will have this situation, you will have an associated arterial occlusion, which will be a standout on the angiogram with respect to blood vessels on the venous side not filling appropriately with time, and the unfilled blood vessels standing out as black lines on the fundus fluorescein angiogram. So certain working caveats, again, which are worth remembering in the clinic. Again, none of these are absolute sacrosanct, but this is what largely you would come down to once you see these clinical findings. So predominant hemorrhages with tortuosity being the most predominant finding, the diagnostic lead is a vein occlusion. Relative macular pallor or a fundal pallor, it could either be an old occlusion or a combined occlusion. If your predominant findings are cotton wool spots, especially with attenuation of blood vessels, entertain the possibility of a hypertensive retinopathy component or a hypertensive retinopathy standalone. If there is internal reflectivity on OCT, this I will come to in the OCT part of my presentation, that leads to an arterial occlusion. whenever you have an unusual finding in a usual clinical constellation. When I say a usual clinical constellation means, again, a pattern recognition. Your mind says that it's a CRVO, but then you are seeing that things are pale, things are not as red. So that becomes an unusual component in a usual clinical setup. So always think of possibility of more than one pathology. And as I showed you in the previous angiogram slide, if you're seeing leakage around large vessels, entertain the diagnosis of a venous occlusion or a large vessel occlusion, because that is when the large vessels would leak. Now, again, one photograph where you are seeing hemorrhages. Patient comes to you and says, I have diabetes. So once you have a history of diabetes, hemorrhages, hard exudates, cotton wool spots, so your mind will say is a possible diabetic retinopathy. But look at this particular area. Is my cursor visible?
Yes, sir.
Yes, yes.
Yes,
Yeah,
sir.
all right. So look at this particular area. Now, this is not three-dimensional, but if you try to assess, you will realize that this lesion and this lesion, there are certain differences. The border is
Vitreous
very,
opacity.
sorry,
Vitreous opacity is that?
that is one possibility that it could be in something in the vitreous. So someone who said vitreous opacity has picked up the point that this is a deeper looking lesion. This is a more superficial looking lesion which is looking more towards us. All right. So
Yeah.
yes, one differential is in the vitreous cavity. Second point, if I tell you that when I saw this patient on a 78D, this did not seem to be in the vitreous. This actually seemed to be in the superficial retina, right? So how does that put a different perspective to it? This is not a soft exudate or a cotton wool spot like what this is. This is a cotton wool spot, well demarcated, deep into the retina. This is right on the surface of the retina, has fuzzy, hazy borders, and even the area surrounding it shows a little bit of haze. Now, this area corresponds to what is this on OCT. Again, you see the location of the lesion is in the retinal layers. It's in the inner retinal layers.
You
If you
are
look
not
at
audible,
this,
sir.
am I audible now?
Yes, yes.
All
Just
right.
check
Your
your
So
voice
net.
is breaking, sir.
uh, my voice is breaking, is it? I actually am in a good internet.
No,
No,
Is
you're
my voice
clearly
this
audible.
is
breaking for
perfectly
everyone?
audible, sir.
No, no, you're clearly
This is
audible.
very clear, sir.
All right, then possibly it
Audible,
may
sir.
be a local issue for the particular resident.
Yes,
Yeah,
I think so
so,
because it's clearly audible. Yeah.
all right,
Continue.
right.
Yeah.
So if we see this, like I said, corresponds to the lesion being in the inner retinal layers. So if I say that this was a region of a small area of retinitis, right? So can any resident from whatever you would have theoretically read at least tell me what is the commonest cause of retinitis that you see in the clinic in an otherwise immunocompetent person? All right. So that happens to be toxoplasma retinitis. So if you see the entire fundus actually is a
Fog.
diabetic retinopathy, but this particular lesion does not fit into the pattern. So you should account for each and every clinical finding. Suppose we would have taken this as possibly a cotton wool spot or a hard exudate and would have missed it, then we would have possibly not started this patient on anti-toxoplasma therapy and things would have gone on the wrong channel. So if you see, we diagnosed him as an associated toxoplasma retinitis and also gave him anti-toxoplasma treatment with Bactrim. Because he was a diabetic, we did not give him Bactrim and oral steroids. Steroids were given intravitreally as a local dose so as to not derange his blood sugars. I do not have a final photograph of the patient, fundus photograph, but if you can notice, this is a change that we got about 2 weeks down the line. You can clearly see that the borders which were more fuzzy here have already started getting delineated. So this is how you can possibly pick up an associated problem that is occurring in the eye if you account for each and every clinical finding that you are seeing and try to fit it into a jigsaw pattern. coming to this photograph, minimalistic findings. So what exactly is this lesion? Anyone? What does this most commonly look like? Small whitish spot in the retina. Okay, this is also a cotton wool spot. So this is an isolated cotton wool spot, right? Not very common that you will see this, but you may see. But even a single cotton wool spot tells you that the area there is ischemic. There is some amount of ischemia going on. And the commonest cause is undiagnosed hypertension or diabetes mellitus. So a fundus like this, once in a while, you get for people who have come just for a refractive evaluation, and you pick this up. You may ask them a leading question regarding their underlying systemic status, and they may tell you that things are otherwise fine. They have never had a problem. But if you find this, you need to do a workup for blood pressure, diabetes, and try and rule that out. Once those are ruled out, there is another big list of why a cotton wool spot can occur. And based on what is your clinical setup for that particular patient, you should slowly escalate and do further tests. Say if it's a female in the reproductive age group, you see this blood pressure, diabetes is largely ruled out. But say there is a history of abortions that may have occurred, or missed pregnancies that may have occurred, then you have to think in terms of APLA syndrome. If there is someone who gives you a history of any underlying tumor or a carcinoma, then you should look for a history of radiation therapy. So depending upon what is the condition, a cotton wool spot should lead you to that particular workup. But the point to note here is even a single cotton wool spot should not be taken as innocuous. One should work up the patient appropriately to try and find out what has caused that particular cotton wool spot. So coming to just shifting gears, coming to something called as retinal detachment. You will have this commonly in your clinic, invariably as one of the clinical cases in your exam. And yeah, you may be asked for a short note or something in your theory. So you see a detachment, but you do not see a break. The right photograph is showing a break. The left photograph is something else that we will come to. So this is a classical horseshoe tear that you are seeing in the periphery of the retina. Perfect. But suppose you are seeing a rhegmatogenous retinal detachment. You are seeing corrugations, and your mind is saying it's a reg RD, but you are not able to pick a break. Is there any other way that you can clinch and come down to, okay, fine, this is what it is. I have not found a break, but I have found a different finding, which tells me that the patient is harboring a break, and thus that finding plus possibility of break plus retinal detachment is equal to a rhegmatogenous retinal detachment, because you have to differentiate a detachment from an exudative or a tractional also. So how will you come down to a rhegmatogenous? So any thoughts? What is that different finding that can lead to that sort of a thought process? So this is a slit lamp photograph, and if it may be difficult for everyone on their screens, but this horseshoe tear on the slit lamp photo is associated with pigment dusting in the anterior vitreous. So why that occurs? That is because there is RPE, retinal pigment epithelium, from the exposed RPE. When you're seeing a horseshoe tear, what are you seeing below? What you are seeing below is not actually choroid, because the anatomic cleavage plane is between the photoreceptors and the RPE. So what gets sheared away are the 9 layers of the retina. What is left behind is the RPE. So what you are seeing in the base of the tear is RPE, and with eye movements and with traction of the vitreous over it, this RPE gets dispersed in the vitreous cavity and is visible often. In most cases, not all, but in most cases, you would be able to see it in the anterior vitreous on a slit lamp, thus corroborating your initial clinical clue that this is a possible rhegmatogenous retinal detachment. This is just a slide on different levels of ischemia. The commonest one that we know is a cotton wool spot. So this is associated with flame hemorrhages, as I showed you in the previous slides. This is present in the superficial retina as the arrow is pointing. Now, this occurs due to a nerve fiber layer ischemia or infarct. Now, similar ischemia or similar infarcts can occur in different layers of the retina also. Though cotton wool spots are maximally spoken of, you can have something which is in the center of the retina that is called as a paracentral acute middle maculopathy. and something which is in the external part of the retina, which is called as an acute macular outer retinopathy. So this is a part of the same continuum, just depending upon which area of the retina shows ischemia, the nomenclature differs. Another fundus photograph. Can somebody quickly take this? Any of the residents try and decipher what these findings are? Again, you are having hemorrhages, but there is one finding which is slightly different. Can someone attempt? There's one standout finding which is different in this eye hemorrhage than what I showed you in the previous photographs.
Spot.
Correct. Absolutely. These are Roth spots. So what are Roth spots? White-centered hemorrhages. So whenever you have Roth spots all over the fundus, there are a few basic differentials that you need to think of. And one of the commonest differential in this situation is anemia. So this is right from the case sheet of this patient. She came to us with diminished vision 4-5 days ago. And seeing the Roth spots, we asked her first to get her complete differential count. And this is where the issue was. Her hemoglobin was 4.8, which is phenomenal. For a 4.8, you would actually expect a patient to possibly be breathless and dyspneic coming to your clinic. But this also indicates that maybe there was a little bit of equilibrium in her body, and she could possibly have been a chronic case of anemia. Because she was a middle-aged female, did have a little bad obstetric history. One also has to look for other causes of anemia, obviously not in the spectrum of the ophthalmologist. The physician would do all that. But what was important is the Roth spots indicated to us that the primary pathology is not in the retina per se, but it is in the systemic control. And once that was done, appropriate therapy was taken. Look at the dramatic change in the fundus. This is how she came to us with, and this is where she was at the last follow-up at which I could take the photographs. 99% of them have completely cleared, save one or two small ones here or there. So there is one condition, as we know, as endophthalmitis. An important thing in a B scan in an endophthalmitis is the fact that you will see a lot of echoes throughout the vitreous cavity in that particular clinical setup. So a patient either having had trauma or having had some amount of some sort of surgery being done before, followed by redness, pain, watering, swelling, and absence of complete visualization of the vitreous cavity. When you do B scan, you would see echoes in the vitreous cavity. Now, beyond the echoes, you would see areas which are hyper-echogenic, right? All of these stand for the coats of the eye. And then you will see one vertical cylinder, one horizontal cylindrical like echo, which is of the optic nerve. But this entire area is pretty compact. If this area develops another small hypoechoic fluid pocket, that actually indicates that the inflammation has sort of gone across the inner aspect of the eye through the walls of the eye and is now in the periocular tissue. So that is an exudation fluid pocket in the periocular tissue. This is an important clinical finding which indicates deterioration. This indicates that the endophthalmitis is now progressing to panophthalmitis. When we say panophthalmitis, the patient usually in a full-blown PANOPH will have some amount of proptosis, will have a very, very symptomatic eye, and there will be classically restriction of ocular movements which would come in, which otherwise are not known in endophthalmitis. But this clinical finding may be something which can lead you to an early PANOPH even before full-blown clinical evaluation shows you a panophthalmitis. So a very important indicator, because if you see this patient requires immediate IV antibiotics with a steroid cover to bring down this inflammation. Or else there is a very genuine risk of this actually spreading and becoming an orbital cellulitis. Right. So OCTA, these slides I will go to in the OCT presentation. So I stop here as far as my clinical slides were concerned. If there are any points of discussion, we can take them here. My later slides are to do with a bit of basics of FFA, bit of basics of OCT, and bit of basics of OCTA. I don't think we can cover everything, but I leave it up to you, Dr. Sharma and Dr. Beke, as to how we go forward here.
Dr. Beke, would you like to add some inputs?
Madam, as Dr. Vivek rightly pointed out, I think it would be a good take-home message for all the residents to work these patients up in a very systematized manner, rather than jumping directly to the diagnosis. And
Dr. Beke,
especially,
please start your video, please. Yeah, we can't hear.
I'll just stop share.
No, it's okay. Yeah.
Yeah.
just wanted to put it across as a message, as in, Dr. Navi already pointed it out. But it would be a good idea for the residents to, work up the cases in a very systematized manner and not jump to the diagnosis. As in the first slide, someone did comment that it's a case of vasculitis. So I think it would be a good idea to, work up a case in a systematized manner, as in they would note the vitreous findings first, then the optic disc, then the retinal vessels, then the macula, and then the periphery, and then periphery with indentation. I think something in that format. I mean, the formats can vary, but I think if they work in a systematized manner, they won't miss out on the findings.
Correct. Dr. Kabra, you want to add something?
Pretty well covered, ma'am. Yes, put in a very systematic way. I think that's the way to go about it. Two simple things we can add up to this. We have to find out two things. First, where is the lesion? You're seeing anything on the fundus, which is in vitreous, which is in the retina or subretina. A simple clue is to follow a blood vessel close to it. A lesion which is in the vitreous, that is in front of the retina. If you follow a close blood next to it, it will disappear behind the lesion. That means the lesion is in front of the retina, that is in vitreous cavity. If it is at the level of retina, the blood vessel gets merged in that lesion, but will not be discontinued. You can place the blood vessel over totally. And in the base, if the lesion is behind the retina, there's a choroid, you can place the blood vessel entirely over the lesion, but it will not be any smudginess around the lesion. So it's a simple clue of follow blood vessel next to the lesion to find out where is the lesion, is it vitreous, retina, or subretina. That's one clue. And second thing, you have to find out the active or inactive disease. As Dr. Dave already pointed out, the active disease will have definitely some signs like vitreous cells will be there. The borders will not be demarcated, it will be fuzzy borders. And the colors will be very lightish color. The healing lesion will have demarcated borders, these are pigmented lesions. So two simple clues, whether it's the lesion, the vitreous or retina or subretina, follow the blood vessel close to it. Just simply press the blood vessel over the lesion. You get the clue where is the anatomy of the lesion. And second, whether it's active or inactive, follow the borders and the color of the lesion. That's too simple point to add. Otherwise, very well covered, Dr. Dave. Excellent.
It was excellent.
May I also
Dr.
add?
Yes, please.
Yeah. Ma'am, may I also add that while we are, looking at the retinal evaluation as a part of this PPE, it would also be noted that a thorough evaluation of a retinal case can only occur if you also take your anterior segment evaluation and the adnexal evaluation equally more seriously. For something like CRVO, central retinal vein occlusion, if you miss a finding like a presence or absence of an RAPD, or let's say in a case of altitudinal, picking up of an altitudinal defect for a case of ischemic optic neuropathy, and if you hastily dilated the pupil, it's a good take-home message for all the residents that you need to know the things which the clues of which would be lost to dilate the pupil very hastily. So the anterior segment evaluation also needs to be taken equally seriously, and we should not be missing out the clues which might play a big role in the algorithm in working of retinal disorders.
Yes, true. Residents, Gayatri, Madhumita, or anybody, do you have any questions to ask? Or any your queries, your doubts?
I think it'll be nice for residents to ask in whatever little time we have, because going to other presentations would,
no, we have time. It's not an issue. If they have questions, they can ask. Otherwise, we'll go for the second presentation.
Sure.
Ma'am, we can go ahead. I think sir has cleared many of the.
Put in chat box.
Yeah, you can put in chat box if you want, so that he'll start his second presentation and then we'll answer those queries as well. I guess, Dr. Vivek, you can start your second presentation, please.
All right. So should I go for fundus fluorescein angiogram or OCT or OCTA. I'm not sure whether we can finish everything.
That is resident's choice. So please
Yes,
tell
so
us.
that's what I'm putting it to the
Sir,
residents.
FFA, sir.
Sir,
All
FFA.
right.
I think you stick
All
to OCT, I guess, to start with. There'll be more easy.
Correct. So, all right. So let us say we go for OCT because that possibly among the three that I mentioned is the most commonly done. So just a moment. All right. I hope the screen is visible again.
Yes, it is.
All right. So the importance of an OCT is that it gives you an immediate cross-sectional view of your retina. It's like an optical scan of the retina. It's like you cutting a fruit across and being able to see all the layers through. It's very quick. It's non-invasive. It's repeatable. It's comparable. And like we said, it gives you different layers of the retina, and the newer OCTs now even give you layers of the choroid. So an ideal investigation in the retina clinic to be able to judge pathology, to be able to judge follow-up, and to be able to judge in what area is the problem existing. OCT came to vogue multiple decades back. Just for the residents' interest, this is the first OCT image that is known in literature. This is how the first OCT looked like. Just compare it to what we see nowadays, and you'd realize that we've really come a very long way. So this is a classical OCT scan that we see in the clinic nowadays, with each and every layer of the retina very distinctly visible. And as our skill to acquire OCTs and our skill of deciphering diseases progresses with every passing year, you will find that this is a field which is maximally changing, with new nomenclatures coming up, with the new disease entities being described with respect to what affects what layer of the retina at what time frame of the illness curve. But largely speaking, for residency level and also for a general practice level, few basics that are time tested and are time standing are what we will go through today. So usually you would ask for an OCT to diagnose subclinical macular lesions, something which you have not been able to pick up clinically, but you are suspecting that something's wrong. Say, for example, a foveal atrophy. A foveal atrophy is not often very clearly visible. You may just see it as a dull foveal reflex, but the vision may be 612. So what explains it? So that is where you may look at doing an OCT to characterize the location and extent of macular lesions which you have picked up, to decide on treatment protocols. One of the most important things to monitor progression and response to whatever therapy you have given. For academic documentation, if somebody is doing a thesis or trying to do a study. And very important, extremely important in today's time, patient counseling. So you tell a patient that you have a lamellar macular hole, the patient is not understanding nuts. So you need to show him his normal eye. You need to show him the eye that has got affected and show him that this is what a normal would look like. And this is what has happened in the eye that has got affected. And that is the reason why we need to operate. And again, it would help you in the post-operative phase to try and show him how the macular hole has responded to the surgery. So those would be the indications. Now I come down to something that I would say OCT scan reporting. So this is a typical normal looking OCT, but one should go about that OCT in a particular manner to be able to sort of put your point across in the exam without missing any specific important point, or also in the clinic to be able to assess the patient appropriately without losing out on any clinical feature. So this dark area now, this is a light based investigation. So when you are talking of light based investigations, you will talk in terms of hyperreflectivity and hyporeflectivity. As in contrast, a B scan or an ultrasound is a sound based investigation. So there you will talk in terms of hyperechogenicity and hypoechogenicity. So here you see a big, large signal void or hyporeflective or rather a reflective area which is present in front of the retina. So that would be your vitreous cavity. Depending upon what is the status of the posterior hyaloid, you may or may not see anything in the vitreous cavity. Here you are seeing this white reflective line. So this stands for the posterior hyaloid. So when you describe in the exam, you talk of the vitreous space, then you talk of the vitreoretinal interface. When you say the vitreoretinal interface, that becomes the area which is just at the junction of your retina and the hyporeflective space in front of the retina. I will show you examples of disturbed vitreoretinal interface going ahead. Then you talk of the layers of the retina. And after talking about the layers of the retina, you talk of the retinal pigment epithelium and then the choroid. Now, depending upon what sort of OCT scan is there in front of you and its penetration, whether it is a time domain, whether it is a spectral domain, whether it is a swept source, or it's an enhanced depth, you will get different depths of imaging and you may not see the choroid clearly. But you always progress in a systematic manner of reporting about the vitreous cavity, the vitreoretinal interface, the retinal layers, subretinal space, the retinal pigment epithelium, and the choroid. So if you go in that way, you will not miss anything at all. All right. So I come to certain examples and know how you would describe them. So here you would say that this is a optical coherence tomography of a patient where the vitreous cavity is showing small hyper reflective areas or a small hyper reflective dots with a clear space between their posterior most aspect and the retina. The vitreoretinal interface in the center, if you see, is normal. So you are having the normal foveal dip and rest is looking normal. But towards the edges, again, you are seeing this white reflective line. So what is this likely to be? This is likely to be the posterior hyaloid. So these are most likely what we call as floaters in the vitreous cavity. This is the posterior hyaloid. So this OCT is from a time frame in the patient's eye where possibly the posterior vitreous detachment has begun but has not completed. So it's like an incomplete posterior vitreous detachment. If you look at this particular vitreous floater or this particular reflective element in the vitreous, this is particularly dense. Why we are saying this to be particularly dense is the light that has come in from the machine lens has hit this and has not crossed it. Hence, this is throwing a shadow on the retina behind. So this is called as back shadowing. So whenever you have something dense in front of the retina, the corresponding area, the retinal image will become hyporeflective in that entire vertical axis. So this tells you that whatever is there in front of the retina is dense. So that also helps you make your own differential with respect to what that is likely to be. All right. Now look at this again, a different sort of a photograph. A posterior vitreous detachment. This has largely got completed in one part of the retina, but has not really completed in the other part of the retina. Now this may or may not be a complete connection because this is a one particular section. If in that particular section the continuity is not there, you will see this to be broken off. Suppose a section would be in any other particular direction, in that you may see this to be continuous. So what is also important when you're interpreting OCT, especially in follow-up, is that you are taking exactly that clock hour or you're taking exactly that protocol of imaging that you have done in the pre-intervention phase. Only then will be your comparison. Only then your comparison is going to be valid. An important observation also in any OCT is the thickness of the nerve fiber layer. If you look at this particular wedge, which is looking hyper reflective, if you look at the corresponding wedge here, there is hardly any wedge here, whereas there is a prominent wedge here. This you will see in most OCTs that you see. Look at our first photograph also, a prominent wedge, but not so prominent wedge. What is this difference? This difference is with respect to what part of the retina has got imaged. This area actually is nasal. Whenever you see this wedge, that area is nasal because this is fovea. Here would somewhere would be the optic disc. And this wedge is actually representing the convergence of fibers of the papillomacular bundle. So this area is thickest with respect to the retinal nerve fiber. That is the reason why you will see this wedge. If you cannot make this out or you're not sure about it, you will also in all OCTs actually have a small graph here, which will point to the directions. So you see N is here and T is here. It tells you that this part of your image is temporal and this part of your image is nasal. That again tells you that this is the nasal area, this is the temporal area, this is where the disc would be, and this constellation of findings makes this image to be the image of the right eye. So even if somebody has not told me whether this is a right eye or left eye, this particular observation can let me know that this is a right eye image. Similarly, this would become a left eye image. Now this photograph has been cropped, hence you are not seeing that graph or that temporal and nasal marking that I told you, but you can go back to your clinics, and if you look at any print, it will always have that scale there, which helps you guide what is nasal, what is temporal. Again, because this is nasal, you see the very prominent wedge of retinal nerve fibers and not so prominent temporally because of convergence of the papillomacular bundle nasally towards the optic disc. So this is how a complete PVD is. The entire hyaloid has gone off the retina and it has not caused any disturbance on the surface of retina whatsoever. It has cleaved out absolutely smoothly. Now look at this. Here you are seeing an incomplete PVD, something where the posterior hyaloid has separated from the perimacular or the perifoveal retina, but at the fovea, it has not really separated out. There is another thing that this particular scan is showing. Look at the previous scan and look at the foveal contour, right? So this is the vitreoretinal interface observation that you need to put across. Here you will see that the vitreoretinal interface is normal, whereas here you will see that the vitreoretinal interface shows reduction or obliteration of the normal foveal dip. So what has happened here? The posterior hyaloid is attempting a natural PVD. While it has cleaved off successfully from the perifoveal retina, right at the fovea, the adhesion must be strong. Now, depending upon how the vector forces play, multiple things can happen. Either the hyaloid can just stay attached to the fovea in the normal contour, or if the pull of the detaching hyaloid is strong, it will pull the fovea up like what it has done here, and the foveal contour is obliterated. So this is called as a vitreomacular adhesion or a vitreomacular traction. You will use the word adhesion if the foveal contour is maintained. Here, because the foveal contour has got disturbed, you will qualify it further and say it's a vitreomacular traction because it is pulling on the center of the retina. So such patients are sometimes symptomatic. Such patients are sometimes symptomatic with respect to metamorphopsia or vision loss. If that is so, then this becomes an indication for surgery where you need to go in, operate, and separate the posterior hyaloid off. If the patients are not symptomatic, then this is something that can be observed, and in due course, either the patient will become symptomatic and then that would be the correct time to operate, or the patient may remain asymptomatic and this is something that can just be observed. Now look at these two vitreoretinal interface issues again. A vitreomacular traction again because the foveal area is obliterated. You are not seeing the foveal dip well. Now you are also seeing an irregular cystic area within the fovea. In the lower photograph, you are seeing the cystic area to be larger. These two images actually indicate that the pull on the fovea has been there for a good amount of time and it is strong. That is the reason what it is doing is it is pulling and cleaving or sort of shearing the layers of the retina such that you are getting these cavitations. So these patients who develop these sort of cysts in the fovea are definitely those that have symptoms in terms of vision or metamorphopsia, and that becomes an important indicator for surgery. An important caveat for the VR surgeon here becomes the thickness of the roof of the fovea in such cases. This is again an additional information that the OCT gives you. If this roof is very thin, it tells you that your surgery has to be very, very guarded. Your steps and manipulation has to be slow, because while you are attempting to detach this entire posterior hyaloid on table operatively, you may end up absolutely de-roofing this area, and then you will create a vitreomacular traction problem into a macular hole problem, right? So this is again an additional input that the VR surgeon gets by doing an OCT scan like this before any surgery is attempted. Now look at this. Again, a vitreomacular interface issue where the pull is so strong that it has not only lifted the retina up from its base on the RPE and created a fluid pocket, it has also sheared off the layers of the retina and created a lamellar retinal hole. So these areas, these patients, when one is treating, not only requires the removal of the posterior hyaloid, but will also require an additional step to repair the hole formation that has occurred. So these subtle differences that you are seeing in this scan or in this scan may not be absolutely clinically distinguishable on an examination in the OPD. And the OCT evaluation in such cases becomes paramount to help us distinguish what is the level of pathology in these cases. A different type of vitreomacular interface issue, this is called as an epiretinal membrane. If you see here, the entire foveal contour is completely lost. The retina looks as if it's one slab of tissue, and on it you are seeing this hyper reflective, very well delineated layer. This is one sort of, or if you would say, a plateau sort of a formation of the contour of the fovea due to the epiretinal membrane. This is the classical epiretinal membrane formation where you see something called as saucerization of the fovea. So if you see the foveal dip, which is usually gradual, because of this epiretinal membrane becomes abrupt. So this and this actually forms a near 90 degree. So this edge has become abrupt. In an absolute classic saucerization, even the second edge would become abrupt. Here the second edge is still a little, sort of having a shallow slope. But here you see this is an abrupt sort of a dip. This is due to a centripetal contraction of the epiretinal membrane. The epiretinal membrane has myofibroblasts. So that is fibroblastic tissue with contractile property. And the epiretinal membrane contracts centripetally. So physics wise, there are two terms, centrifugal and centripetal. So if this is the epicenter, anything which is moving towards the epicenter is called centripetal. Anything that is moving away is centrifugal, right? So this epiretinal membrane, as it forms and contracts centripetally, what it does is it crumples tissue towards the center of the fovea. That is the reason you get this right angled bending and saucerization occurring at the center of the macula. Now, this saucerization pathology is actually something which is more dramatic on OCT than what it is for the patient. You may find that somebody with this sort of an OCT still has a near 6x vision and may not be very symptomatic. That actually happens because though this tissue has got crumpled here, the underlying photoreceptor orientation may not have got disturbed. If the underlying photoreceptor orientation has not got disturbed, the patient will not get metamorphopsia. Or if there is no dropout of photoreceptors, there will not be a loss of vision. So though the OCT may look dramatic, if the patient has largely vision which is good for his or her own daily activity, then one does not need to intervene. So a different interface problem, that is epiretinal membrane. So this is the patient who was symptomatic. You can see a very prominent epiretinal membrane. The foveal contour has not only got lost, but you are actually having edema right in the center of the macula. This patient underwent an epiretinal membrane peeling, and this is the photograph of the patient post-op. So if you can see, the entire foveal contour has got re-established with time. This change would not occur immediately as you remove the epiretinal membrane, will take time. Often it can take from 4 to 8 months for the entire contour to come back to normal on the OCT scan. Right? So after interface issues, we come down to issues regarding retinal layers, and the classical OCT, pathologic OCT with respect to the retinal layers is a macular hole. So very easy, not at all difficult to pick up. There is a complete discontinuity in the retinal layers. The edges of the holes are usually edematous, so you will see these fluid pockets which will be visible through the retinal tissue. This actually becomes a good prognostic marker. If the edges are relatively showing more hyporeflective spaces, it is taken as that the hole is relatively fresher, and that is the reason where you may get a better closure. There are certain other indices which are there on small observation again. It's very important to keep observing. Another small observation here is, look at the entire reflectivity of the choroid here. Look at the reflectivity of the choroid here, but look at this central reflectivity. If you all are with me, you will agree that this central wedge of reflectivity is much more. It is much wider than what is the reflectivity here and here. Why is that happening? That is happening because there is a hole. Because there is a hole, the light which the machine is sending across is not encountering any tissue before it hits the RP and the choroid. Hence, by the principle of OCT, more light that hits and reflects back, brighter will be that particular area. That is the reason why this area is bright. So it is not that this area has some different pathology. It is just that there is a greater transmitted reflectivity that you're seeing. That is the reason this is. So this is exactly opposite of shadowing. You are seeing more signal go through. Another example of more signal going through, there is atrophy here. If you trace the retinal pigment epithelium, the retinal pigment epithelium is throughout visible till here, and then it is gone. What you are seeing here is the Brooks membrane. If you trace the photoreceptor here, the photoreceptor area comes till here, and then again it's gone. There is no more photoreceptor going ahead. This is again the what is called as the external limiting membrane. The external limiting membrane comes till here, and then it's gone, and you are not seeing anything further. So what has happened is the entire bunch of outer retinal layers have become atrophic in this area, and the inner retinal layers have sort of dipped down to cover this particular space. So what happens? For this choroidal reflectivity, the light has to traverse through these many layers. For this area, the light has to travel through lesser number of layers, especially the RPE being deficient here, the pigmented layer being deficient here. There is a free pass of lot of light across, and hence much more reflectivity back. And that is the reason why this area is brighter. So this does not indicate a choroidal pathology. It only indicates that the reflectivity is higher because of greater transmittance. That is because superficial or the above lying retinal layers are deficient. So I was alluding to the observational table in my first presentation, that if you see inner hyper reflectivity of the retina on OCT, think of an arterial occlusion. This is what I was alluding to. So this fundus photograph is a branch retinal artery occlusion. So if you see, the entire area here has stopped getting perfusion. The retina, which has its normal pink color and luster, has lost it and has become opalescent and white. Okay. So this scan is the scan which is corresponding to this particular line here. So this part of the scan is the upper part of the retina, and this part of the scan is the lower part of the retina. Now look at the difference in reflectivities of the retina. Here you can discern all the retinal layers perfectly fine. The nuclear layers are dark, the nuclear layers are bright, the nerve fiber layers are sort of darker. But if you look at the area which has been involved with the retinal artery occlusion, because this entire area is ischemic, all of these layers have got swollen up and their reflectivity has increased. So this is a classical finding in a patient who has developed a branched retinal artery occlusion, or you will see a similar thing mirror imaging on this side if it's a central retinal artery occlusion. So it's classically seen as edema and increased hyperreflectivity of the inner retinal layers. Look at the comparative outer retinal layers, they are largely okay. In fact, because a lot of signal is consumed by these layers, the lower layers look a little darker because that much relatively less signal goes through. But you do not see any increased reflectivity in the inner layers. After the retinal layers, you come one layer below. This is the area where you see subretinal fluid on an OCT. This is a classical subretinal fluid OCT of a CSCR. So you are seeing the entire retinal layers nice and intact. Only thing that is different is between the retina and the RP, you are seeing this subretinal fluid pocket. So this is how an SRF would look on an OCT, classically an OCT of a CSCR. This is what happens once the CSCR either spontaneously resolves or the patient may have undergone a laser therapy to seal off the leakages. With time, the fluid goes away and the OCT gets back to its own contour. Vision improvement, though, may be differential from patient to patient. Now, look at this carefully. This is a fluid pocket, right? But the retinal pigment epithelium is right in its place, right? The hyperreflective layer. As against that, look at this here. The hyperreflective layer actually has got elevated. All right. This is a perfect looking dome. Within the dome, you have clear fluid. That is the reason light goes across and you are also able to image areas of the choroid. There is nothing that is blocking the signal. So you have RPE. RPE is getting elevated. Under the RPE, you have a hyporeflective or areflective space. So tells you it is some sort of a clear space or a clear fluid. And the light goes through across and images the underlying choroid. So this is a retinal pigment epithelial detachment. This classically, if you want to qualify it further, is a serous retinal pigment epithelial detachment. These are how drusens look like. So the retinal structure is normal. You are seeing RPE, which is undulated, and between the RPE and this fine line, I hope you all can see this, and this fine line, which is the Brooks membrane, you are seeing sort of reflective material accumulated. So more here, little less here, one more here, one more here. So these are drusens. So multiple drusens which are there. Classical lipofuscin material accumulating between the retinal pigment epithelium, which is elevated here, and this fine line, which is the basement of the retinal pigment epithelium, that's the Brooks membrane. When at that junction, instead of a clear retinal pigment epithelium, you see a fusiform sort of a heterogeneous, some areas of hyporeflective, some areas which are hyperreflective, this sort of an area on the OCT. Correspondingly, in the fundus photo, if you see edema, hemorrhages, or a yellowish grayish membrane, that is what would point towards presence of a CNVM. Over the years, classically clinched as a diagnosis on the fundus fluorescein angiogram, but nowadays a lot of practices are shifting to just doing an OCT angiogram so that you get that vascularity picked up without having to do an invasive test in a patient. Now look at this, the retina. This, because this is a colored OCT, this red one is the higher signal. There is a retinal pigment epithelium. Again, the retinal pigment epithelium is getting elevated, right? But what is the difference? The retinal pigment epithelium got elevated here also. So what is the difference here? The difference here is you are not able to image any choroid ahead of it. If you see here, you are seeing that the retinal pigment epithelium is elevated, but after that, the light is still passing through the underlying choroid. That means this area below the retinal pigment epithelium is something that can allow light to transmit. So it is something which is not reflective. Here, below the retinal pigment epithelium, there is some amount of reflectivity, and then there is an exponential dip of reflectivity. You are not seeing anything here at all. That tells you whatever is filled up here is actually blocking signal. Hence, the signal is not able to go through. This classically is seen in sub-RP hemorrhages. So I've put a fundus photo which is corresponding to this OCT. So these are hemorrhagic retinal pigment epithelial detachments, classically seen in CNVM, or rather a variant of CNVM that we call as a polypoidal choroidal vasculopathy. So a subtle small point, both the OCTs showed an RP detachment, but one of them allowed imaging of the underlying choroidal structures, the other did not allow. This difference is based on what is the type of material filled below the retinal pigment epithelium, and that helps you differentiate what is the sort of pathology that you are looking at. So these were a few OCTs that I thought will be commonly encountered by the residents, and if your exam setups has spotters, then these are the common ones that you are likely to see as spotters. So I'm open to any questions or any further discussion points. Thank you.
Dr. Beke and Dr. Kabra, you can put your inputs, and residents, you can ask any questions to Dr. Dave, but he has explained very well a lot of basics. Even for practitioners like me, this was really good, Dr. Dave.
Thank you. Thank you so much.
Any questions from Dr. Kabra?
Yeah, excellent presentation, Dr. Dave. There's a question from the audience, how to diagnose PVD on a clinical examination?
Yeah, that's a good question. Diagnosing PVD on a clinical examination may not always be easily possible. There have to be certain factors that would come in play if you are looking at diagnosing a PVD on clinical examination. One is, suppose the posterior hyaloid is completely transparent, right? If it's a completely transparent posterior hyaloid and it's an incomplete PVD, then it is near impossible to diagnose a posterior vitreous detachment. Classical way in which you can diagnose is if it's a complete PVD and a Weiss ring has got created. So you will see that the hyaloid that has got separated from around the optic nerve, because the optic nerve per se would not have a hyaloid over it, you will see a small ring or opening. So when you examine, you will see a small ring which is floating in the vitreous cavity. That would indicate to you that the posterior hyaloid has detached off. Second way is if the posterior hyaloid is little translucent, not really transparent, then one has to do a 78 or a 90D examination. A 78 is better here because things will be a little more magnified, and slowly move your joystick either from posterior to anterior or from anterior to posterior. And if it is little translucent, you will end up reaching a particular plane where you will see sort of a avascular membrane which is translucent looking in the mid vitreous or the posterior vitreous cavity. That would again indicate to you that that's a posterior hyaloid. But other than these two situations, if it is not a complete Weiss ring formation, or if the posterior hyaloid is not translucent and is completely transparent, it is near impossible to diagnose it just clinically.
Right. Then another question, how do you diagnose or evaluate a spontaneous venous pulsation? Any technique for that?
I'm sorry, I did not get the question. How do you?
Look for spontaneous venous pulsations. This question from the audience.
Spontaneous venous pulsations. Yeah.
How do you look for spontaneous venous pulsations?
Venous pulsations.
All right. So two things again here. When you say spontaneous venous pulsations, there's something called as spontaneous venous pulsations and something called as an induced pulsation. So if it's a spontaneous venous pulsation, you will actually see it pulsating, right? So that's why we call it spontaneous. So rather than how you look for it, the thing will be, it would indicate towards something. So spontaneous venous pulsation will be something that you as surgeons would either encounter in the clinic or on table. In the clinic, the situations where you encounter commonest is something where you have a raised intraocular pressure. If the patient has a very high IOP and the intraocular pressure has risen above the pulse pressure, then you are going to see pulsations which will be occurring at the disc. Second thing is an induced pulsation. Induced pulsation is something where when you are examining, say you are doing a 90D examination or you are doing an indirect evaluation, if you bring one of your fingers close to the eyeball and just give a very mild touch or a pressure to the eyeball, very minimum pressure, you will start seeing the blood vessels at the optic disc pulsating. This is indicative of a slow flow circulation in your eye. This is usually looked for when you are seeing patterns of hemorrhages which are mid-peripheral, patterns of hemorrhages which are dot plot mid-peripheral and are associated with little dilated blood vessels. In this given setup, when a mild pressure on the eye is enough to reduce the circulating pressure in the eye below arterial pulse pressure, that is what is called as an induced pulsation, and this indicates an ocular ischemic syndrome, right? So just to summarize, if you're seeing a pulsation spontaneously, it is likely to be raised intraocular pressure. Mind you, I am ruling out any abnormal vascularity, any angiomatous malformation is ruled out. In a normal looking eye, spontaneous pulsations, if you are seeing, think of raised IOP. Second way that you can have that is if you have injected something in the vitreous cavity, you may have given intravitreal antibiotics or steroids or gas injection. After that, if you look at the fundus and if you see pulsations, again, it indicates that the IOP is high. In that situation, you may have to do an AC tap. And the third is induced pulsations, where mild pressure by your finger on the surface of the eyeball leads to pulsations occurring close to the optic disc. This indicates that that pressure has risen above the perfusion pressure of the eyeball, and that indicates a slow circulation inside the eye, which is a corroborative evidence of a possible ocular ischemia.
Any other question, Dr. Kabra? Or you want to add something, Dr. Beke?
Ma'am, the only, am I audible?
Yes, yes, you are.
Yes, yes.
Yeah, the only point which I wanted to add is in all the OCT images that we saw so far, I think like anywhere else in ophthalmology and indeed in medicine, you would need to correlate everything clinically, apart from the clinical picture that we see. And it also needs to be seen that OCT image is essentially, as Dr. Dave pointed out, it's a cross-sectional image. So it makes, it matters a lot where exactly you're taking this cross-section from. I've seen people misdiagnosing a case of central serous retinopathy because the scan wasn't passing through a choroidal neovascular membrane and was passing actually through someplace else. So, it makes sense, whatever you see clinically, and that's why Dr. Dave's presentation, in my mind, the prior presentation was even more valuable because, unless you see the things clinically, your mind won't open up to ordering the right investigation and expecting a very sensitive and a specific finding in the investigations ordered.
That's a very valid point. Clinical correlation is a must. Just investigation or just looking at OCT, you have to first see a fundus properly. And not just fundus, when anterior segment as well. And not just anterior segment, also examine the patient as a whole. Always take proper history as well. Whether the patient is hypertensive, as Dr. Dave had said, hypertensive, diabetic, always see the person as a whole. He is a patient. He's not just the eye. So we say always the eyes are the windows of our body, and eyes do diagnose a lot of systemic problems, but we have to take proper history, proper clinical examination, and then go to the investigations. It was an excellent presentation, Dr. Dave. I would request Dr. Kabra to say vote of thanks. I would also like to thank all the PGs who joined, and I hope you have gained a lot today. Many of them have already written in the chat that it was an excellent presentation. Yes. So over to you, Dr. Kabra, and Dr. Vivek, if I can request you, if you stop sharing, we'll have a grid photo of everyone as memory for POS.
Yeah.
Yes. Thanks a lot.
Yeah. On the behalf of Poona Ophthalmic Society, I wish to thank our guest speaker today, Dr. Vivek Dave, for excellent talk, a very enlightening talk, very simplified talk, which was useful not only for the PGs but also for the clinicians. Special thanks for President Dhanjali Sharma ma'am for bringing up this concept of postgraduate education. Our secretary, Dr. Mukesh, who is not in the meeting, but who works behind this quite hard to make every program a success. Our managing committee, who takes a decision and bring everybody together to form these different programs. All our POS members, special thanks to our expert, Dr. Nikhil Beke, who put in valuable inputs for today. Our PGs, Dr. Gayatri, Dr. Mudita, for participating today. Thank you all POS members, all participants who join all over India today for this excellent webinar. Hope you all benefited from this. And also special thanks to Alembic for giving the technical support for this today's program. I wish you a very good Sunday evening here onwards. And thank you very much once again. Thank you.
Thank you, sir. Thank you for the presentation.
Thanks a lot.
Yes.
Thank you, sir.
I thank everyone.
Can we get such a lecture series?
Sorry,
Hello?
come again? Yeah. You said
sir, can we hello, can we get lecture series for FFA and all, sir?
That is, I think,
there is a very good feedback. I think they talks about Dr. Vivek Dave again, excellent webinar today. So it's a very positive feedback. Definitely we'll arrange one more for you.
Yes,
okay?
yes. Lecture series for FFA set. So
Okay.
definitely we'll invite, yeah, again, and we'll definitely have it.
Sure. It'll be my pleasure.
Thank you,
No
ma'am.
issues. We can.
Yeah.
we
Thank
can
you
make
so
it
much,
happen.
sir.
Yeah.
Thank you.
And because of this webinar, we can arrange all this. Because of COVID pandemic, we have got this opportunity. I must say that. Otherwise, in physical meeting, every time I wouldn't have been able to invite faculty from all over India. This is the opportunity that we have got POS when I can invite, we can invite best faculty from all over India for the benefit of our students. Thank you, Dr. Dave. Thank you, Dr. Beke, Dr. Kabra, everyone who joined and who have put the inputs. And thank you, Alembic, for the technical support. Thanks a lot.
Thank you.
Thank you. Thank you so much.
Thank you, madam.
Thank you. Have a great evening.
Thank you,
everyone.
ma'am.
Thank you.
Thank you.
Yeah, have a great day.
Yes, sir.